Welcome to the Healthful Woman Podcast, the fastest growing podcast in women's health. Today's Monday, May 6th, 2024. Today we have a Mailbag podcast with me. What does the fox say? I'll be answering questions from our awesome listeners, Gabriella, Rachel, Aaron, Riley, Katie, and one anonymous listener. Yes, you can submit questions and ask to keep your name anonymous. Topics covered today are vast, and they include gel manicures in pregnancy, Group B-strep, a prior pregnancy with fetal growth restriction, drinking alcohol while conceiving, bungee jumping in pregnancy, and partial molar pregnancy. Before the Mailbag podcast, a few things. First, I feel the need to say something about what is going on at many college campuses today, including my alma mater, Columbia. Essentially, it is sickening. Overall, I am a fan of free speech and protests against or for a cause you believe in, even if it is a little disruptive from time to time, because our country has cherished that form of democracy for a long time, and overall, it served us well. But what is happening now is not that. First, the cause itself has such a large undertone of anti-Semitism and, frankly, outright Jew hatred. Sure, some, or even many, of the protesters might simply be fighting for a cause they believe in and have no malice or anti-Semitism in their hearts. I get that. But clearly, a large portion of them are disgusting maniacs who have no problem calling for death to Jews or supporting an overtly terrorist organization, Hamas, that would gladly behead all of them just for being American. So, the protest itself has a very ugly side, and that alone has no place on a college campus. Imagine if the protest had a large percentage of hood-wearing KKK members screaming their hateful vitriol in the middle of a college campus. Is there any chance that wouldn't be shut down immediately? The blatant dishonesty and double standard in some of these universities and how they handle anti-Jewish factions as compared to anti-anyone else is astounding and horrific. Shame on the universities. Second, the methods of protest are also not okay. Just because you have a cause you believe in does not give you the right to disrupt everyone else from going to class, walking through campus freely, and getting a good night's sleep. The universities set rules for this, which is absolutely within their legal right. If a protester chooses to break these rules to make a point, fine. But take your punishment like a big boy or girl. You break the rules, there are consequences. Don't whine about getting arrested when you did something to get yourself arrested. Oh, and don't expect the college to deliver your meal plan to you either when you barricade yourself in the building. All right, I had to say that. On a lighter note, the book I wrote with Emily Oster is now officially available wherever you buy books. In fact, after this intro and after the Healthful Woman Orchestra plays our theme music, you will be treated to an ad for the book, followed by the podcast. Also, some book signings. On May 14th at 7 p.m. in Washington, D.C., there is a book signing at Politics and Prose with Emily and me. Yes, I am planning to be at that. It is going to be hosted by Abby Phillip, who anchors CNN Newsnight with Abby Phillip. On May 22nd at 7 p.m. at the JCC on the Upper West Side of Manhattan, there's going to be an event and book signing. It is going to be a conversation with Emily and me, followed by signing of the book. So please do sign up for that. We would love to see you and meet you. I believe that the admission fee comes with a copy of the book. Oh, one last thing. I'm starting to post on my own Instagram account, or at least I will be trying to if I can figure it out. For those of you on the Instagram, please feel free to follow me. My handle is Dr. Nathan Fox. One word, Dr. Nathan Fox. All right. Thanks for listening. See you all next week. Welcome to today's episode of Healthful Woman, a podcast designed to explore topics in women's health at all stages of life. I'm your host, Dr. Nathan Fox, an OBGYN and maternal fetal medicine specialist practicing in New York City. At Healthful Woman, I speak with leaders in the field to help you learn more about women's health, pregnancy, and wellness.
Hi, I'm Emily Oster.
Hi, I'm Nate.
Here's a piece of data for you. About 50% of all pregnancies include some type of complication, whether that's a miscarriage, preeclampsia, preterm birth, postpartum depression, or other. I'm not saying this to scare you, but the reality is that we don't talk about these complications very often. and yet they affect an enormous number of people. That's why I've teamed up with Dr. Fox to write a new book called The Unexpected: Navigating Pregnancy During and After Complications.
The Unexpected is a book we hope no one needs to read, but we also want everyone to have access to. It starts by laying out the data on pregnancy complications from first trimester to postpartum. For each one, we try to answer a few questions. What is the risk of recurrence in a later pregnancy? What treatments might lower that risk? And how can you better prepare if it does happen again?
Then we guide you through how to have more productive conversations with your provider. Data will help, but to make these hard talks as useful as possible, you need a script and a way to structure the conversation.
It's important to us that we bring these maternal health issues into the light so that necessary research and policy change can hopefully happen.
And above all, we hope it helps pregnant women feel less alone and more informed and prepared for whatever the future brings. You can order The Unexpected now, wherever books are sold.
Hey everyone, welcome to our 9th Mailbag podcast. What does the Fox say? We're getting a lot of questions and we're going to keep answering them. So please keep them coming. All right. Question number 1 today comes from an anonymous listener, which also serves as a reminder. If you send in a question, you do not need to attach your name, or you can just note in the question that you want to remain anonymous and we will do so. Although this question is an awesome question, so I don't think I need it to stay anonymous because it's so great. Here we go. I just found out I am pregnant and was wondering if I'm still allowed to get gel manicures. Thank you and love the podcast. So full disclosure on this answer, I had to do some research on what a gel manicure is. So I guess that says a lot about me and who I am. And I realized I think I have heard of them. I've seen people get them before, but I had to do a little brush up on my gel manicure science in order to answer this question. So the short answer is yes, you can get gel manicures when you're pregnant, as far as we know. There's no reason to think that the gel, the chemicals, or whatever it is can somehow harm the baby or you, during pregnancy. Again, it's hard to study this perfectly, but there's no real suspicion that it's harmful. There seems to be some potential issues related to allergic reactions. Apparently, some people get allergic reactions to their gel manicures, and allergic reactions, particularly on the skin, are more common in pregnancy. So it's possible that if you are someone who normally gets gel manicures with no issues, that you may start to get allergic issues in pregnancy, which would not be so unusual. It's also possible that at some point in pregnancy, most likely closer to delivery, someone might ask you to remove the nails. Like if you're having a C-section or this, and they have to monitor certain things related to your finger, that could happen. So if you're going to get a gel manicure and it's going to be very expensive, maybe don't do it close to delivery without checking with your OB or midwife if that is a potential issue. All right. Good question. All right. Batting second, Gabriella, who has a question about GBS. Hi, Dr. Fox. I'm a new listener, heard you on the toast, and have really been enjoying the podcast. I was wondering if you would do an episode regarding women who are GBS positive. I have 4 children, thank God. Nice work. And had a very scary experience when my 4th child was born. My results from the GBS test came back negative, and therefore was not given antibiotics during the delivery. However, about an hour after my son was born, the nurse noticed that he was having difficulty breathing and didn't sound right. They sent him to the NICU, where he was put on a CPAP machine. They saw that his organs were starting to shut down and gave him 4 antibiotics before even knowing what the problem was. When the results from his test came back and they told me that I was in fact GBS positive, I was devastated and frustrated. I felt like I had gotten my baby sick, even though I did everything I was supposed to do. My son was in the NICU for 2 weeks, but thankfully made a full recovery and is now a very healthy 2-year-old. Again, thank God. Do you have any patients who experience this? Do labs make this kind of mistake often? What can be done to prevent this situation in the future? Thank you so much. All right, great question. I am sorry that you had that experience and your baby had that experience. I'm happy that he's healthy now at age 2, so that's terrific. So as some background, so GBS is Group B-strep. It's basically a bacteria, it's a bug that about 25%, 1 in 4 women have it, right? It's called colonized with it, meaning if you do a vaginal culture or rectal culture, you'll find this bug in about 25% of women. It is not an issue for the health of the mother, right? So during pregnancy, the Group B-strep it's not an infection. There's nothing wrong with having Group B-strep. It's not an issue if you're not pregnant, meaning we would never check for Group B-strep on someone who was not pregnant. The reason it's relevant in pregnancy is that Group B-strep can be dangerous for newborn babies, and they can get it during delivery. Typically, the way they would get it is during delivery, particularly vaginal delivery, as they go through. If the mom is colonized with Group B-strep, the baby can get it and then get infected with it, and it can be very dangerous for them. If the mom gets antibiotics while she's in labor, it greatly reduces the chance that the baby's going to get Group B-strep. So what do we do knowing that about 1 in 4 women have Group B-strep, and giving antibiotics lowers the chance of the baby getting infected with Group B-strep, which could be problematic for the baby. So there's different strategies of what to do. The current accepted strategy, which has been for a long time, is basically everybody in pregnancy gets screened for Group B-strep towards the end of pregnancy, usually 35, 36 weeks, give or take. And that's basically a culture. It's a swab, a vaginal and rectal swab, gets sent to the lab. They culture it and they look for Group B-strep, and it's either there or it's not there. So again, about 75% of people will be told you don't have it, and about 25% of people will be told you do have it. And then for those who have it, when they come in labor, we give the mom antibiotics, something like penicillin typically, either penicillin itself or ampicillin. If there's allergies, there's a whole algorithm for what we do. So a few things about that. Number one, it's not 100% effective, right? Even with this strategy of screening everybody and treating those who are positive, about 1 in 1,000 babies will get infected with Group B-strep. So why would that be? It could be that the culture that was done didn't find the Group B-strep that was actually there. It could be that they found the Group B-strep, but the antibiotics didn't work. It does not necessarily mean that the lab made a mistake, quote unquote, right? It could be potentially that the swab wasn't collected properly. That's a possibility. It's possible that there was no Group B-strep at the time the culture was done, but someone can develop it after the culture was done, right? So we do the culture 35 to 36 weeks. We do it at the end of pregnancy because we want to get as close to delivery as possible, but not miss an opportunity. So we do it around 35, 36 weeks, but it is possible that if someone doesn't have it at 35 weeks, they could have it at 38. It's a bug that sometimes comes and goes. So that's another possibility. It could be that the Group B-strep was there and it was collected appropriately, but for some reason it just didn't grow on a standard culture. And so the lab didn't see it. It doesn't mean they made a mistake. It just means it didn't grow. And so the short answer to your question, Gabrielle, is yes, we have seen that. There are moms who get swabbed, it comes out negative, and the babies are born GBS positive. Again, fortunately, the chance of the baby getting very sick is low, about 1 in 1,000. But, 1 in 1,000, in a hospital that has thousands of births, it's going to happen, right? So it does happen. Fortunately, with treatments of the baby, they do well, like your baby is doing. In terms of the future, one of the things we do with Group B-strep screening is there are certain people we don't screen, we don't do a swab, and we just automatically treat them in labor. So one of those is someone who's had a baby with Group B-strep infection before. Why do they automatically get treated the next pregnancy? Again, the thought is maybe there's something unique about them or about the strain of Group B-strep they hold or something. And also obviously the sort of like the emotional trauma of going through that. So they're automatically treated. Other groups who are automatically treated, someone who had Group B-strep in their urine earlier in pregnancy, like sometimes we do urine cultures in pregnancy. And if we find Group B-strep in the urine, we don't bother culturing at 35, 36 weeks. We just assume they're positive and we treat them. So for you, presumably every future pregnancy, if you have any, they would treat you with antibiotics in labor, no matter what. You wouldn't even need to get cultured. Great question. All right, Rachel, here we go. Hello. Thank you so much for an entertaining and informative podcast. I've listened to almost every episode. Hey, thanks, Rachel. All right, I listened to your last Mailbag episode and really appreciated your advice about having a preconception appointment to review past pregnancy questions. I think I'll do that ASAP myself, since I have had 3 pregnancies, 2 of which had IUGR. Do you have any suggestions about what to ask during this appointment? I do have the lab reports from my placentas as well as the reports from all of my scans. I still don't know why I had 2 very tiny babies and would like to avoid the stress of that in a future pregnancy if possible. Thank you so much, Rachel. All right, Rachel, first of all, thank you for listening. Thank you for the nice email. Thank you for the question. Yes, I think it is worthwhile to have a preconception consultation for you. And in general, if someone had any complication of pregnancy, it's often very helpful to have a preconception consultation. Now, not always, obviously, it depends on the exact circumstances. And the reasons to do that, again, this is review because you've already heard this in a prior podcast, but the main reason to do it is to try to understand what happened, why that complication occurred, if possible, to try to also help process that. There's like an emotional component to that sometimes, again, based on what it was, and to see if there's anything that needs to be tested and possibly done prior to a next pregnancy, and to map out a plan for the next pregnancy so you don't have to start figuring that out when you're pregnant the next time. So that's sort of the reasoning behind this. I find them very valuable myself on the doctor end of it, to have an opportunity to meet with someone before they're pregnant, to go over things. Sometimes there's things that need to be done before pregnancy. Sometimes it's just to plan. Things that could have been done at the beginning of the next pregnancy, but it's just sort of nice to plan ahead so everyone's on the same page for what happens. Okay, in terms of your specific situation, so you had 3 pregnancies, 2 of which had IUGR. So IUGR, for our listeners, stands for intrauterine growth restriction. It's often called nowadays fetal growth restriction, same thing. It's basically a catch-all phrase for when the babies are born small, or if we're doing an ultrasound during pregnancy, we suspect that the baby is small, meaning smaller than expected for how far along in pregnancy you are. There is a wide range of possibilities for what causes this, right? And so when I meet with someone either during pregnancy or after pregnancy who has a suspected small baby, or baby was born and actually had a small baby, the majority of the time, there's nothing wrong, right? That some babies are big, some babies are small, some babies are tall, some babies are short. It's like, there's a lot of variation in human sizes. That's true with adults. That's true with children. That's true with newborns. And so most of the time a baby is small. They're just whatever. They're on that end of the curve versus a baby being big, and there's no issue whatsoever, fortunately. Now, sometimes there is an issue where the baby was, quote unquote, supposed to be bigger, but the placenta maybe didn't provide enough nutrients to the baby. Again, that's rarely an issue with the mother, right? There's usually enough nutrients in her body, but it's just the placenta, which is supposed to transfer those nutrients from her to the baby, was for whatever reason not working well. There are tests in pregnancy that we can do that will suggest that's the case, either suggest it a little bit or suggest it strongly. And on the flip side, if they're normal, that would suggest there's no issue with the placenta, or if there is, it's mild enough that we don't really need to do anything other than watch and wait. Those are the 2 most common reasons a baby would be small. Either the baby's just normal and small, or the baby's supposed to be bigger, but the placenta is not working completely. And then there are other more rare causes that are more concerning, like if there's a genetic abnormality in the baby or an infection in the mother sometimes. Rarely, but some infections can do that, or something else like some other exposure potentially that she has that can be causing this. Now, in pregnancy, sometimes we have a good sense of what's going on, sometimes we don't. But if the baby's already born, having that consultation will help us sort of go through the possible causes of having a small baby to see, was there any other concerns in the baby after birth, health-wise, genetic-wise, something like that. Assuming no, then we're generally left with the first 2 causes. The baby's just small and healthy, or there was an issue with the placenta. As you noted, you can get pathological examination of the placenta where they look at it. Sometimes it's helpful, sometimes not. It's not always a great direct correlation between how the placenta appears on pathology and what's going on with the baby. It's a science that is still evolving, and for many people somewhat mysterious, because we can see placentas that look horrible on the reports and the babies are fine. And you could see placentas where the report's like, placenta's great, and the baby was, very small or whatever it was. And so it's not a perfect correlation. There are some circumstances where we want to send blood work to see if there's any issues with clotting. And there's, some circumstances where we want to check maybe the shape of the uterus. And, again, there are sometimes things that we can pick up. I would say most of the time I see someone for a pre-pregnancy consultation about a prior baby that was small, assuming the baby's healthy and there's no concern for a genetic condition. We usually don't know for sure, was it the placenta or is the baby supposed to be small? And if it was the placenta, it's not like it's definitely going to recur. So all we typically do is, talk about it, make sure there's nothing else, crazy going on. And then the next pregnancy, just sort of watch to see how the baby's growing with ultrasounds. So it doesn't tend to be a very complicated consultation, but a lot of people find it very helpful, mostly to see if there's anything that didn't get tested last time or didn't get thought about during the last pregnancy that may have been the cause of the small baby. All right, Rachel, thank you for that question. Next question is from Aaron. Hi, Dr. Fox. I learned about you from the Toast, and I've been a listener ever since. I'm 27, and my husband and I have started talking about having kids. I want to go into the whole process as leniently as possible and hope to keep my lifestyle more or less the same, at least in the beginning. I do enjoy the occasional glass or two of wine, particularly on weekends, and I can imagine us getting pregnant on an evening when I've consumed alcohol. I know the general medical advice is to avoid alcohol at all costs when trying to conceive, but I can't imagine that everyone is always completely sober when they conceive. Wine is an aphrodisiac after all. Smiley face emoji. How dangerous is it really? Should I completely give up alcohol for the unforeseen future until I'm pregnant? Also, what if I have a drink after getting pregnant and just don't know it yet? So, Aaron's a great question. We get this question all the time. It's really, really common. Alcohol can be very dangerous in pregnancy to the developing fetus. That is a true statement. However, a few things should be noted, and that's specifically related to the amount and to the timing. So in terms of amount, there is very good evidence that large amounts of alcohol, and different studies define that differently, can cause something called fetal alcohol syndrome, which is not good. And it can also cause other neurodevelopmental issues in the newborn, children, and beyond. So because of that, alcohol is typically avoided in pregnancy, and it's recommended not to drink in pregnancy. The question, though, is how much alcohol, right? Is it any amount? Is there a threshold below which it's perfectly safe and above which it's very dangerous? Are there sort of gradations where a certain amount is very dangerous, another amount is a little bit dangerous, and another amount's not dangerous at all? Is it like if you have one glass of wine, will it drop the IQ point by 1? And as far as we can tell from all the evidence that we have thus far, there does seem to be a threshold. And different studies define it differently, but having a glass or two of wine a week is below that threshold. However, it's defined. Sometimes it's like 1 drink a day. Sometimes it's X amount per week. But 1 to 2 glasses of wine a week is below the threshold in those studies. And in the studies where they looked at a very either moderate or low, however they name it, amount of alcohol consumption, let's call it 1 to 2 glasses of wine a week, give or take, they've never been able to find any issues with it. Meaning when they do studies and look at long-term outcomes on children born to women who had that kind of alcohol exposure in pregnancy, they haven't been able to identify how that could be risky. Now, that either means there is no risk at all, or it's so small that it's not perceivable in a study like that we haven't been able to find it, but maybe one day we will. It is true that the recommendation in pretty much every organization is not to have alcohol in pregnancy. But I would say the reasoning behind that recommendation is not because it's known that very small amounts are dangerous. It's because there's no proven benefit to having 1 to 2 glasses of wine a week. So the thought is, okay, we know that high amounts are not good, so don't do that. Low amounts we can't prove are not good. They might be not good, but there's no real upside to doing the 1 to 2 glasses of wine a week. So that's why pretty much everyone recommends not drinking in pregnancy. Again, when I see people, I'll tell them that as far as we know, it's safe. And it's not like, therefore someone might conclude, all right, I'm going to have a glass or two of wine a week because I really enjoyed it, I really needed it, it relaxed me, whatever it is. And they're saying, all right, the risk is either non-existent or very, very low, but it's not like we recommend a glass of 2 or wine a week because it's not known to have benefit. So that's the terms of the amount. So just the amount you're talking about is probably not particularly dangerous, as number one. Number two, the timing, right? So in order for something to affect the development of the baby or an organ in the baby, it really has to be present while that organ is being created or developed. So for example, things that can lead to abnormalities in the fetal heart, in terms like the structure of the heart, would need to be present at the time the heart is being formed, which is early in pregnancy. So it's in the sort of middle to end of first trimester. So someone's on a medication that could possibly cause a heart defect, but they don't start it, let's say, until the mom is 16 weeks pregnant. Well, the heart is fully formed by that point, so it's not going to cause a heart defect. Now, obviously, there are things that can affect the heart in other ways, like the heart rate or the rhythm. Okay, so that's a different thing. But in terms of the structure, like it's not going to cause a hole in the heart that wasn't already there. So that's it. Now, there's also an earlier end to that. So if it's before the heart is being formed, the same principle applies. So if someone's on a medication and that could, in theory, cause a heart defect, and they stop it before the heart is being formed, it also should not increase the risk of a heart defect in that particular baby, right? It has to be during the window where that heart is being made. Brain development, which is really the main issue with alcohol, is ongoing throughout pregnancy, which is why we wouldn't tell someone, hey, you're 16 weeks, it's okay to start drinking heavily, because the brain, unlike the heart, is not so much the structure, but more the function. And so the brain function and sort of development happens throughout pregnancy. So the recommendation not to drink heavily lasts the whole pregnancy. But on the other end, it does seem that there's also an early, like a starting line, before which it does not seem to have an impact. And so generally, the development of the brain is not going to begin within the first few weeks of conception, right? From when you conceive until you get a positive pregnancy test is typically about 2 weeks, give or take. And so in that 2-week period, when someone might be drinking, might get pregnant, but not know they're pregnant, it seems to be too early in order to cause issues with brain development, right? Alcohol leaves your system quickly, like, within a day. So it's not like it lingers on forever. And so if someone was drinking until they got a positive pregnancy test, it does not appear to cause any of those issues, even if it was in higher amounts. So that happens frequently. It says, oh my God, I got drunk and I got pregnant, and now what? So they may not want to be pregnant. That's a separate issue. But in terms of risk to the baby, it does not appear to do that. It appears that if someone has something quote unquote toxic that early, if it's that bad, it would potentially cause a miscarriage, but should not cause, as far as we know, sort of neurodevelopmental issues in the baby because it was done too early. So with all of that in mind, for your specific question, I don't tell people that they have to stop having a glass of 2 or wine on the weekends before they know they're pregnant, or if they got pregnant when they had more to drink that night, as long as they're not continuing after, certainly after a positive pregnancy test, or even possibly a little bit after that, it should be fine. So I wouldn't change that. Okay. Next question is from Riley. This is a new one. I started listening to you because of the toast. My husband and I are traveling to New Zealand, the bungee jumping capital of the world. We are also trying to conceive. If I do become pregnant, I would be about 4 to 5 weeks pregnant during our trip. Is it reasonably safe for me to bungee jump? Wow. I would never bungee jump my entire life. I'm terrified of heights. That is like the last thing on earth I would ever do. I'm also not likely to be pregnant. So this question is doubly not relevant to me. I have not heard this question before. Pretty hard to study this one. Not sure how anyone would do a really good study looking at pregnant bungee jumpers and what the effects are. I would say that in general, what are the possible risks, right? So the possible risks are the altitude. Okay, but the altitude does not seem to be an issue. People are allowed to go up on a mountain. People are allowed to live at high altitude. So that doesn't seem to be an issue. There's the concept of the sudden jerking when you're jumping off and then you get pulled back up. There are situations in pregnancy where sudden jerking like that can cause what's called a placental abruption, where the placenta separates, like if people are in car accidents, and there's a problem, that's frequently the reason, the abruption. Now, which is not really relevant at 4 to 5 weeks because there is no placenta and it wouldn't really separate. So that doesn't seem to be an issue. The main issue is probably just related to injury, right? That certain activities might be more likely to cause injury. Number two, when you're pregnant, you're more prone to certain injuries, like related to your joints and whatnot, because they're a little bit looser in this. And so I would say it's hard to say for certainty what is the problem specifically with bungee jumping at 4 to 5 weeks pregnancy. And more likely than not, I would think it's not going to cause a problem, particularly if you don't get injured. It's unlikely to do anything. But, it's really hard to say anything like that with great confidence. I found this online when looking up bungee jumping. Quote, "Bungee jumping during pregnancy is highly discouraged." I think that sums it up. I probably wouldn't be so keen on someone bungee jumping at any point in pregnancy. Again, more related early in pregnancy to the risk of injury, later in pregnancy to the risk of abruption. I don't get asked a lot about bungee jumping. I do get asked a lot about skiing, and it's conceptually the same, right? Skiing is not a problem. It's not a problem to get on skis. It's not a problem to go on the altitude. It's not a problem to be on the chairlift or go on the gondola or even ski down the mountain or anything like that. The problem with skiing is you could fall, or someone can plow you over. Even if you're an amazing skier and you never fall, you can get run over by somebody and you can injure yourself. And even early in pregnancy, when it's not so much a risk of like placental abruption or this, if you tear a ligament when you're pregnant, it's harder to treat. It's harder to have surgery for that. It's harder to rehab. If you're on bed rest, you're more likely to get blood clots. I mean, all these things are worse when you're pregnant. So we really discourage people from doing activities which could lead to injuries, whether it's an orthopedic injury, whether it's a head injury, whether it's an injury causing bleeding, whatever it might be. We generally tell people to avoid those in pregnancy for that reason. So I would probably put bungee jumping in that category. All right. We're really rolling today. So the next question is from Katie. "Hi, I'd love to hear you discuss partial molar pregnancies. I've had 2 this year, one in March at 10 weeks and one in August at 11 weeks, and there seems to be very little information about them and the recurrence risk. My husband and I had genetic testing and chromosome karyotyping, and there were no issues found. And we also have 2 children who we had no problem with conceiving, no issues. I'm currently 4 weeks pregnant, and I'm just searching for more information on partial molar pregnancies to understand my risk of a third fully." Okay, Katie, great question. So this is going to require a lot of background. Molar pregnancies are confusing. Interestingly, they were first described by the man himself, Hippocrates, as in like the Hippocratic Oath, in the year 400 BCE. There are lots of other names for molar pregnancies. Another one you might hear is something called gestational trophoblastic disease or gestational trophoblastic neoplasia. Essentially, the way to think about a molar pregnancy, it's when a pregnancy, more specifically the placenta, starts to behave like a cancer. If you think about it, cancer is generally an unusual and unchecked growth that doesn't stop, right? And that's why cancer is a problem. Now, pregnancy has a lot of overlap with that. Pregnancy is a time of rapid growth, right? You go from 2 cells to a full baby and placenta in 9 months, right? If it wasn't a baby and placenta in any other part of your body, that would be horribly abnormal. But in pregnancy, obviously, it's desired. But every now and again, this rapid growth that's happening in the baby and the placenta sort of flips and behaves like a cancer would, meaning it doesn't stop growing after either a miscarriage or delivery or whatever it is. And this can happen to different degrees, right? A smaller risk to a very high risk. And so we categorize them typically as something called a partial molar pregnancy, which, Katie, was what your question was about, or a complete molar pregnancy. So a complete molar pregnancy, the pregnancy, usually there's just placenta, no fetus, no baby. It's a very abnormal placenta with a lot of growth, something we call hydropic. It's filled with like fluid. if you checked the chromosomes of the placenta, they look normal, right? There's a normal number of chromosomes, 46, but actually it typically happens when you have an empty egg and then one sperm that has twice the amount of DNA, or two single sperms fertilizing that empty egg. So at the end, you end up with 46 chromosomes, but instead of 23 from the egg, 23 from the sperm, you end up getting 0 from the egg and 46 from sperm. And that causes some sort of like chain reaction where this no baby and the placenta just goes gangbusters and is growing, is growing, is growing. It is dangerous. There's a very high HCG, which is a pregnancy hormone level, high risk of bleeding, and that is a higher risk of leading to a cancer, typically in the uterus, and then it can spread. So that's a complete molar pregnancy. A partial molar pregnancy can have a fetus, can even have a heartbeat, but they very commonly miscarry, that they don't develop and they miscarry. And so frequently they're not even diagnosed, right? So if someone had a partial molar pregnancy and there's a fetus or an embryo with or without a heartbeat and then they miscarry, you wouldn't even know it's a partial molar pregnancy unless you happen to send the tissue that came out to a pathologist and they look under a microscope and say, oh, this is molar or hydropic tissue, and you have a partial molar pregnancy. In terms of the genetics, there typically is extra chromosomal material. So instead of 46 chromosomes, it tends to be 69 chromosomes. So 3 times instead of twice, called diploid 46, it's actually triploidy, but usually it's 2 sperm fertilizing 1 egg. So you get 23 from the egg, 46 from the sperm, you have 69 chromosomes. This can turn into cancer, but at a much lower rate than in the complete molar pregnancy. Now, whether someone has a partial or a complete molar pregnancy, the treatment essentially is to empty the uterus. Either she's already miscarried with a partial molar, or you do a D&C and you empty the uterus of the placenta. And often that's all that needs to be done. And the way we verify that is we do serial blood tests, every week, every month, whatever it is. There's a lot of protocols until the pregnancy hormone hits 0, the HCG is 0. And then you continue to verify it's 0 for X amount of time. And then we're highly confident it's gone and is not coming back. There are situations when it does not go away or it does come back, where someone either needs a repeat D&C and sometimes even chemotherapy. Fortunately, this kind of cancer is almost entirely and universally treatable if it's recognized, diagnosed and treated. That again, most people need nothing or just 1 D&C. Some people need a repeat. Some people need chemotherapy, but it tends to be very effective and it tends to be curative. Okay, so that's the background for what we're talking about here. The incidence, the likelihood of a pregnancy being molar, seems to be about 1 in 1,000, right? So pretty low, not 0, but pretty low, 1 in 1,000. Interestingly, and this is relevant to your question, Katie, one of the risk factors for having a molar pregnancy is having one in a prior pregnancy. So for someone who had a molar pregnancy in a prior pregnancy, instead of the risk being 1 in 1,000, in the next pregnancy, it's now 1 to 2%. So 1 to 2% is low overall, but that's 10 to 20 times higher than everyone else. If you've had 2 molar pregnancies, like you have, the risk seems to be 10 to 25%. So again, more likely than not, you won't have one, but it's definitely a higher chance the more molar pregnancies you've had. We don't know definitively why that's the case, but it's probably because of some genetic predisposition, either in the mother or the father, to have an abnormal egg or an abnormal sperm. There have been a few genes that have been identified that can increase the risk of a molar pregnancy. So in Katie, you said you had normal genetic testing. It depends what they tested. If they just checked your chromosomes, I'm sure yours came back normal as 46XS and your husband came back normal 46XY, but that wouldn't be the testing that would need to be done. There's very specific molecular testing to see if you are one of the people or your husband that carries a specific mutation that can lead to an increased risk. That's something that in order to do that, you probably need to have an appointment with a genetic counselor or a geneticist, and they can talk to you and see what's going on and arrange that testing to find out, to see how high your risk of recurrence might be. Wow, that's a really tough topic. That is a hard thing to explain. Molar pregnancies are really confusing, really tough. But again, Fortunately, most of the time they are totally treatable and just end up being frustrating or annoying. But usually if they're treated well, they can be dangerous, but ultimately are not if they're treated well. All right. This concludes our 9th Mailbag podcast. Thank you, everyone. Please keep sending in the questions and we'll keep doing them. Have a great day. Thank you for listening to the Healthful Woman podcast. To learn more about our podcast, please visit our website at www.healthfulwoman.com. That's HEALTHFULWOMAN.com. If you have any questions about this podcast or any other topic you would like us to address, please feel free to email us at hw@healthfulwoman.com. Have a great day. The information discussed in Healthful Woman is intended for educational uses only and does not replace medical care from your physician. Healthful Woman is meant to expand your knowledge of women's health and does not replace ongoing care from your regular physician or gynecologist. We encourage you to speak with your doctor about specific diagnoses and treatment options for an effective treatment plan.